So I'm Dr. Allistair Morris. I'm a consultant paediatrician and I'm an Associate Medical Director at Calderdale Huddersfield Foundation Trust. My role within the EPR programme was the CCIO, or Chief Clinical Information Officer, for the organisation. The main goal was looking at patient safety benefit for the for our patients in our community. So the vision early on was to look at establishing a full electronic patient record with a full suite of order comms, e-prescribing, clinical documentation within the same system, so there was a single source of truth. And we knew from evidence from HIMSS that once you were aiming towards an MRAM level 6 or above hospital, that's when the real patient safety benefits came out from an EPR, and that was our goal at the start of the project.
So I'm Jackie Murphy, I'm Director of Nursing at Calderdale Huddersfield Foundation Trust, and I've got a portfolio for modernisation and transformation. And my role within the programme essentially, I think, was a leadership role around engagement, training, educating, change, getting the organisation ready for the electronic patient record. And I would say that our goal would be look at for patient safety, experience, but also efficiency and effectiveness as well. So looking at the whole broad suite of improving quality of care for patients. I describe it really as very much now we're in that transitional phase of understanding a lot of our data, and I think a lot of where we are now is understanding is having a better awareness of the things that we didn't do well previously that we thought that we did. So having data that tells us and gives us the very specifics really enables us to get in underneath things to examine it further. I think at the moment what we need to do as an organisation is to energise ourselves to start to really utilise that as intelligence and use that towards our quality improvement strategy, and to normalise all of that electronic patient record into how we do make that transformational change, but for colleagues that we work with and for patients. So I think discovery is probably where we're at the end of 2017.
This year we've achieved the go live. I think adoption, I think we've got pretty confident that adoption has now taken place within the organisation. There's very little paper around in the system. Virtually everybody is using the EPR to some degree, a lot more. The questions that are coming to us as clinical leaders on the project now is around optimisation of the system and improvement of the system. When can it do this for me? When can I have that out of it? How do I get this information out of it? Why don't we change this to this way? So they're the areas that we've come in. I think that are looking towards in 2018 is how do we look at optimising the system and spreading the system into areas that currently aren't covered by the EPR on a single platform.
I think, and I speak from a CHFT perspective, I suppose, predominantly, but I can see it in both organisations really. I think the executive sponsorship of the programme was really important, and I think the lead of our chief exec here that took the entire organisation, he really took it, the clinical element of it, really seriously. And supported us to be able to deliver our role within that. So I think that's probably one of the key success factors. I also think that the way that the programme was managed, surprisingly, was also a key success factor. And I think the engagement was a real key success, and that across both organisations. I think if you were to talk to colleagues at Bradford, I think what really helped them was learning the lessons of our implementation for them to do it more smoothly. And I think that wouldn't have been as successful, but for the fact that it's the same team. So you can talk about lessons learned and everybody can hear lessons learned and think, well, that won't happen to us. But actually, if you've walked it and lived it alongside somebody, you really take that part of it seriously.
I mean, I think some of the clinical side of the system, the real strength for the project was actually the clinical agreement we got across the trusts. I don't think we most of the time we didn't struggle to get agreement on the build around the clinical side. You know, I think the clinicians, the nurses, doctors, the AHPs in both trusts work the same at the end of the day, and they agreed on how the build should look. So the build is very generic across both trusts. We both do the same things, and I think that's been a real strength for the project, and that enabled that sort of alignment and engagement of the front end staff in the build and the final testing and then the go live after that. Absolutely. I think without our CEO and the exec board that went along with that, we could have done the project that we did. It would have been a project over there by the EPR team, whereas actually it was bringing it into hospital business. A variety of things we did for engagement. We had our simulation centres that were set up for clinicians, nurses and doctors to come down and use the EPR, the sort of play domain within a more inpatient environment between beds and things. I did one-to-one sessions with over 70% of our consultants, which at least gave them a window into the EPR. And I'm continuing to do that, looking at master classes for the consultants now. They're hungry they've got so much skill, but now they don't feel they can develop it anymore. So we're still coming back, but I'm doing classes rather than one-to-ones at the moment. Okay. So I think that and just being there as a listening ear and hearing what they say and taking what they say seriously, I think is and putting that back into the programme. I think from a medical point of view, I think it's had a wide variety of impact. I think there are some positives in there, and there are still some areas that we need to do further work on. I think in the inpatient setting, the EPR really is coming into its own, having that whole patient record there, the whole information, results, e-prescribing, clinical documentation, the amount of documentation and the amount that people are typing into the system is impressive. It's not just a brief clinical note; it is sometimes quite an in-depth clinical note that's going in there. So all that information is available. The number of datixes we've had around prescribing against allergic patients has virtually disappeared.
Does everyone in the UK know what a datix is?
An incident report has virtually disappeared since we put the EPR in. There's very few allergic patients receiving medications to which they're allergic to. We're starting to see that process. Now we're beginning to populate the record with information from admission to admission, that it's more coming into its own now. I think the areas we struggle around are within our outpatient areas where time's a bit more pressured. And then the fact that we have still a multiple of legacy systems that either need replacing or bringing into the main EPR so that all the information is in one place.
I think in terms of nurses, in particular, inpatient nurses or nurses on inpatient wards, I think they've adapted to it really, really well. I think that their initial introduction by using the nerve centre technology was a really big step, actually. It got them used to using technology in healthcare. So that really helped as part of an engagement. And actually now they're at a point where they've got used to documenting most of the care into an electronic patient record, and they're looking all the time now to how to improve it and how to make it better, and that optimisation side of things. Maybe that enthusiasm needs to be harnessed and somewhat. I think for colleagues that work either remotely, so things like clinical nurse specialists, AHPs, physiotherapists, occupational therapists, our infection control team, they benefit for being able to see a patient record from a distance and be able to prescribe and offer advice. That's they speak volumes about, or they really are enthusiastic about how that's changed their working lives and enhanced patient care. Another
bit on the back of that is actually the junior doctor group. So I surveyed, so we had a group of junior doctors that were with us during Go Live. They went through all the trials and tribulations of Go Live, and then in August they all moved back to paper because they went to a lot of them went to other trusts, and some of them went to Bradford, who went live in September, so they went sort of paper electric, and so I surveyed them once they'd left the trust and said, well, which do you prefer, EPR or paper? And over 50% were very much EPR, and another 30% were more EPR than paper, and about 20% were still with a bit of paper, and a lot of, but only slightly paper over EPR. So they could see the benefits of prescribing from a distance, of seeing the patient record from a distance, that everything was there, it was readable, it was legible. They could really see the benefits of it.
For me, I think the lesson learnt would be that we did a really, really successful implementation, and I think we probably didn't concentrate hard enough on the post-implementation phase. Yeah.
Okay.
Yeah, I think I would agree with you on that. I think very much a lot of people said this to us prior to at different conferences. That it's the start of a journey. It's not the go live isn't the end. It is absolutely the start.
It's just a blip.